Hello, everyone. You are listening to the HP Leader podcast, and we are live streaming an international COVID-19 respiratory physiotherapy update. I'm delighted to see you all today, and we've got a fantastic panel for you. I'd like to first start off by just reiterating the importance of why we're here. So COVID-19 has taken over the world like something we could never have imagined. We've had 48.2 million cases so far, with 1.2 million deaths worldwide. But 34.5 million people have recovered that we know of from COVID-19 infection. We currently have 12.4 million infected with the COVID-19 virus, and 12.38 million of those are in a mild condition, and 88,000 are in a serious/critical condition, which equates to less than 1% of all those infected. The daily death rise is increasing globally, and for many countries, we are now either in our second wave or heading into our second wave. So I'm really pleased that everyone's agreed to come from all different time zones across the world to share their experiences, and that is the purpose of this live stream tonight. So my name's Rachel Moses, and I want to just let everyone introduce themselves and a little bit of background about the country that they're joining us from tonight. So Sue, coming over to you.
Thank you, Rachel. My name's Sue Burney. I am from Melbourne, Australia. I have to say we've been very fortunate that we are a large island, and we've been able to protect our borders, which has really seen us have a very mild effect compared to the rest of the world of COVID-19. We've got a population of 25,499,844. To date, we've had 27,620 cases of COVID-19. The highest number of patients in Australia we've had on a ventilator on any given day is only 46, and that was back in April. And we've had 907 COVID deaths. Melbourne has just come out of stage 4 lockdown restrictions because we had an outbreak that really affected the aged care sector rather than what we saw in the acute sector. Melbourne is in stage 3 lockdown now, which means we can go around Melbourne, we can't leave the metropolitan area, and the rest of Australia is in a mix of stage 1 and stage 2 restrictions.
Thank you, Sue. David, coming down to you.
My name's David McWilliams. I'm a physiotherapist and researcher, and I work at the University Hospitals Coventry and Warwickshire in the UK. We've got a population of around 68 million people in the UK, and sadly over the past week we've just passed our million cases mark for COVID-19, and sadly around 47,000 deaths. We've moved out of the first wave but are very much heading into the second wave now. There's currently today around 12,000 people in hospital, and around 1,000 of them are ventilated in intensive care. So we're seeing numbers rising, and because of that, we're now heading back into a national lockdown provisionally for 4 weeks. But I think we're all kind of wondering how that's going to go.
Thanks, David. Amy.
Hi, sorry. Okay. So I'm Amy Pastra. I'm from Duke University, which is located in North Carolina, in the United States, Durham, North Carolina. And here's a nice picture of Duke. You can see the chapel in the back. I'm not presently on campus. That's my Zoom background, just to give you a flavor. Well, I would say if you look at the total US cases now, as of today, was about 9,385,143. That's up from over 100,000 or plus since Monday. The total cases in North Carolina are hovering around 2,078.28. So North Carolina has actually been one of the states that has had a lower occurrence overall since the pandemic has occurred. But you've probably heard the stories of New York and other places up north that have had a really hard time. And now we are seeing reemergences, probably a second wave that's resulting in more cases, and deaths are now going up in our country again. Part of the reason for this discrepancy among the states is we don't have any national guidelines for how to deal with COVID. It really is state by state and oftentimes local. So I can tell you at Duke, our cases among faculty, staff, and students and employees have been quite low. That's because Duke has really has strict requirements for restriction and following precautions, and that isn't similarly followed across all places in the U.S. So it's been a difficult case here as far as the states go, and I don't think, again, it's hard to predict with our election coming up now what's going to happen as far as mandates for any restrictions. There were initially travel restrictions out of states, and sometimes if you had to go through a state, you had to be quarantined in that state before you can move on to a next state. But those have rapidly changed over time as well. So in other words, if this is not making much sense, it's because every place is following a different precaution, as well as the hospitals. We are fortunate in North Carolina that we have a stable Department of Health and Human Services that are giving guidelines. Right now, we're in phase 3 in North Carolina, and we are allowed to move about to go to the store, but we have to keep our social distance. Some restaurants have now reopened, and so you can go out for dining, which that has affected. And the reason I'm telling you that is because that does affect the population that we see in our hospital. Overall, we've had some low cases, like I said, compared to other places. We do have COVID patients that are spread throughout Duke Hospital. We have many units. We have 4 different separate ICU units. We're also starting now a respiratory care center that will have its own area for COVID patients. But right now, they're still mixed in across the various levels of our units in the hospital. We also have different hospital wards where the patients will leave ICU to go to the ward floor. So I can give you an idea. For instance, one ICU unit generally has about 32 beds, between 23 and 32. And on the new unit, we'll have some more. So again, there's no really consistent thing to say, hey, this has been our population over time, because they have been spread out.
Yeah, and you're such a big country as well. I think that's the other thing, rather than the smaller islands over here.
And also at Duke too, we're a tertiary center. So if a COVID patient is making it at a smaller hospital, they will come to our hospital. So we're generally seeing secure.
Thank you so much, Amy. Rick, coming into you, please. Oh, Rick, you're on mute. I've said it already. Oh.
There. So my name is Rick Gosling. I'm a physical therapist and professor in rehabilitation sciences at Leuven, which is a medieval city in the middle of Belgium. We were quite badly hit by COVID-19, with over 12,000 deaths from the start of the pandemic. Currently, we have 7,000 patients hospitalized in the second wave, so we are not beating the UK, but we are quite in a similar process. At this point in time, we have approximately 1,200 patients admitted to the ICU. Quite a bit of them are on ECMO. And in our hospital at present, we have 160 patients admitted, of whom 50 are admitted to the ICU, and most of them are on mechanical ventilation. So that's the current situation. So we are now in the second lockdown for 6 weeks.
Yeah, we've seen some of the news over here in the UK, Rick. So definitely thinking of you guys over there. Yeah. Michelle, coming into you.
Hi, I'm Michelle Coe, and I'm a physiotherapist and Canada Research Chair in Critical Care Rehabilitation and Knowledge Translation. I'm from Canada, and Canada has a population of 38 million, and we have 10 provinces and 3 territories. As of yesterday, we had about 245,000 total cases, of which 31,000 were active. And most of, about a quarter of the people who have COVID in our country are 60 years or older. Right now in Canada, we have just under 17,000 cases who are hospitalized, of whom about 3,500 are in ICU, and of that 3,500, 820 required mechanical ventilation, or about a quarter or so of those that were admitted to ICU. I live in the province of Ontario, and Ontario currently has 367 patients hospitalized, of whom 75 are in ICU and 44 are mechanically ventilated. And in terms of deaths, we've unfortunately had 10,208 deaths in Canada, representing about 4.3%. And our provinces primarily reporting deaths are in Ontario and in Quebec.
Thank you, Michelle. Ricardo.
Hi there from Spain. Here we are right on the second wave. We have a population about 47 million of people. Number of total COVID cases until yesterday, the data are so. 1.26 million confirmed PCR cases. Number of patients in ICU, I don't have the data on ventilation, but on ICU, nowadays we have 2,754 ICU patients, and that it's about 28% of our country's capacity in ICU, which is a lot. And the total number of deaths nowadays are 36,495 people that have died. Great numbers, and we are right on the second wave.
Yes, thanks, Ricardo. Sabrina.
Hi, everyone. I'm Sabrina from Switzerland. I'm an ICU physiotherapist in a large university hospital. Switzerland is a small country which has about 8.6 million people. In the first wave, we locked down very early because we were close to Italy, and our Italian region was hit pretty hard. But luckily, our lockdown helped, and the numbers weren't so hard. But over summer, restrictions were lifted, and even mass gatherings were allowed again. And so we are currently on a rapid increase. It's exponential, and we are following Belgium, unfortunately, very closely. Currently, we have 200,000 cases, 2,500 deaths, and about 3,300 in hospitals. I don't have the total number who's ventilated, but ICU capacity is about 75% full. And the projections are going to say that approximately this week, some first hospitals will be full, or at least the normal ICU beds. We are not yet in lockdown. There are some partial lockdowns in a few regions, but generally there are still events allowed below 50 people, or gatherings outside with 15 people, and in family below 10. And masks are mandatory, but shops and bars and restaurants are open, schools as well.
Thanks, Sabrina. Malin.
Okay, hello everybody. I'm Malin Nygren-Bonnier, a physiotherapist and associate professor working at the Karolinska University Hospital and the Karolinska Institutet in Stockholm in Sweden. And we also are a rather small country. We have a population of 10.2 million. And to date, there are 137,000 numbers of COVID-19. And the numbers of deaths in Sweden has been 5,997. And today it's, I think there are around 75 patients at the ICU in Sweden. And in Stockholm area, I think it's around 25 patients in the ICU. And we also are in like have sharper restrictions right now, a couple of weeks from now. And so it's a rapid increase here, and there are also a lot of local restriction, and it's all about to avoid public transportations and to try to work at home and to not be too many people gathering, of course. Yes.
Thank you so much. So we've touched on a couple of really important points, and it's how we've responded not only as a profession, but as countries and then as countries within countries. So particularly in Europe, how we've watched our colleagues in other countries. And I think most importantly, had the opportunity to learn. So we are incredibly grateful, particularly to our Italian colleagues, our Spanish colleagues, and, you know, those from Hong Kong as well, who shared so freely their experiences, the things they got right, the things that they had to change and learn from. And this is just another way that we can learn from each other. So with that in mind, David, I'm going to come to you first. And the first thing I have to say is that David's done a whole podcast with me, just a one-on-one about his experiences in the pandemic as one of the worst hit UK hospitals, and how he led his physiotherapy and multidisciplinary team through that. So David, I'd like you to be as concise as possible with that in mind, and just tell us how, you know, you responded, which is very typically to the UK, I have to say, so you can use your experience generically. Go for it.
Okay, so I think we, like most people, were looking overseas at what was happening and what we could expect, and taking a lot of that early information from China and from Italy. And I think when it came very quickly, and we had to learn very quickly. So what I often quote is we went from 18 ventilated patients to 96 in the space of 7 days, which obviously hit the unit quite hard. I think the early expectation from a physiotherapy perspective was that these were going to be very sick, very unstable patients, quite dry, non-productive chests, maybe not a huge role for us in the early stages, but big expectations about rehabilitation. What became very apparent very quickly was there was quite a high secretion burden, often very thick, very tenacious secretions, and this was impacting on their overall stability, particularly their stability when moving from prone back into supine. And we then had the real challenge of thick, tenacious secretions in very unstable patients, often paralyzed. I think 90% of our patients were paralyzed, often for up to a week, prone on multiple occasions, and overweight. So over 90% were in the overweight or obese category, and actually 50% were obese or morbidly obese. So from a secretion clearance point of view, they often needed 2 physiotherapists at least, performing manual techniques, assisted coughs. We used a lot of saline, which I know can be controversial. We tried to get ahead of this quite early on with the use of carbocysteine and mucolytics from admission, really. And there was a lot of nervousness at the time around using humidified circuits, so maybe we were using other measures to try and compensate for this as well. But often trying to treat people who were very prone to desaturation, even with what we considered quite successful secretion clearance, they would still desaturate and take quite a long time to recover, but overall recover to a better position than when we started. And then the other thing that was very apparent with these patients needed quite a high amount of sedation. Any attempts for sedation holds or to wean, they became quite unstable quite quickly. So the average sedation period was a good 10 to 14 days. And then, as we'd expect in any group of patients who were sedated, paralyzed for 2 weeks, they woke up extremely weak. And we had 100% incidence of ICU-acquired weakness. And we were able to get them moving as early as physically possible. And because of that, we've actually published our results, which is in the annals of the ATS. So every single patient moved before they left critical care. And we were able to get them standing and generally step transfer into a chair before they left. But again, the considerations really with the burden around, you've got an obese population, often delirious because of the situation they were in, profoundly weak, with staff in full PPE, limited bed space available because we had 2 beds per bed space at this point. And it made the rehabilitation process extremely challenging, no room for equipment, those sorts of things. So there was a huge rehabilitation burden in critical care, which then translated right through into the ward. And we were able to create a rehabilitation environment to cohort these patients together on the ward. But I still think there was quite a lot of pressure to move people through the system out of intensive care into the ward and out into the community. And that's now leaving this kind of lasting legacy as people have gone out into the community about how we keep this rehabilitation challenge up.
Yeah, and I think part of that was patients wanting to get out, wasn't it?
Yeah.
People didn't want to stay in hospital. We certainly found that in the UK. David, that's a really nice succinct summary. Thank you so much. We'll definitely be coming back to you. Just a note, please, you can put questions in the YouTube chat box or DM me on Twitter if you want them private. We've got lots of questions coming through already. Thank you. Michelle, coming down to you. Thanks.
Oh, great. Thank you so much for having me here. And David, I'd like to congratulate you and thank you for publishing that paper, because amidst all of the crazy, it's really been amazing to see how our critical care colleagues have also published peer review work. Also, Sabrina, you too, having those papers out there to help us understand more about COVID. In Canada, I was involved with the initial guideline or guidance for caring for patients with COVID. And from a systems perspective, our initial efforts were really about ensuring that physiotherapists had access to the appropriate PPE for aerosol generating procedures for patients with COVID. And it became really challenging because trying to define what an aerosol generating procedure was very different across several different types of documents. And even hospitals within the same city would have different requirements for the physiotherapists. And there have been some situations where physiotherapists initially were not provided access to the PPE that they felt that they required to care for patients with COVID. One of the things that we thought was important to do was to also ensure that our other rehab colleagues in occupational therapy and speech language pathology, who were also working with patients with COVID, were also explicitly aware of the different types of aerosol generating procedures, so they also too could advocate for the appropriate PPE. And we worked really closely with national organizations for OT, PT, and speech to ensure that we had language around a common point of care risk assessment so that people could assess for their own safety. And within my own hospital at St. Joseph's Healthcare, we had dedicated physiotherapists to a unit, and we also tried to limit cross coverage within the hospital so that therapists wouldn't move from one area to the next. Briefly, from a research perspective, it's been really amazing to see how people have come together and collaborated to quickly identify clinically important research questions. So I'll look forward to more discussion on that if we have time.
Definitely, Michelle. I wouldn't expect anything less from yourself. Sabrina, I'm going to come into you next to talk about your experiences, and Michelle's touched on the case series report that you've managed to publish unbelievably in these times as well. Thank you.
Thank you, Michelle, and also thank you, David, for this report. I read it with interest as well because it matched our experience with the ICU acquired weakness, what we saw as well. So for us, it also started very nervous, like David described. A lot of energy went in, like to increase services. We went from working from 8 to 5 till 11 in the evening. So we made our first evening shifts. We had to organize all these things. We had to recruit other physiotherapists from other regions, like from pediatrics or cardio, that were gonna help us. And for here, the guideline was actually very helpful because it confirmed our own reasoning, what we thought would gonna be help. And it was very helpful to see that others were thinking the same thing. We decided early on that our main goals in the ICU would be to assist with proning and to manage long-term complications. And for us, this was pretty successful, and definitely for the second wave, we will stick with that. Our other goal in the ICU was rehabilitation, like we have been doing. We are a very early rehabilitation focused unit, so that was our second largest priority. We initially thought that maybe 2 physiotherapists per patient would be needed because the nurses could not assist. But luckily in the first wave, we were not overrun. So we still had 1-to-1 nurse ratio, and we could treat all patients. They really got through treatment, good treatment actually. And it's our main lessons that we learned, that good teamwork and do the basics right, that's really, really helpful for the patient. So I think it's for ICU treatment, but also for the physio treatment, that just do what's evidence-based, the rehabilitations, be careful to avoid complications, and it will help the patient in the end. Our ICU mortality was also pretty low, actually below 10% for the first wave. So I think 1-to-1 nurse ratio and good physiotherapy would be very helpful. Well, on the ward, we also had goals that were respiratory management and rehabilitation. So the respiratory management included like the active cycle of breathing, especially the controlled breathing, or maybe stretching positions, deep breathing exercises, not so much the huffing or coughing, because that often led to attacks. We wrote one case about that in our case series, where a patient just breathing deeply in just a little bit ended in huge coughing fits and desaturations. So that was another thing that we saw, that David saw as well, rapid desaturations, and you always had to monitor and go very slowly and to individually adapt your techniques. Yeah, I guess otherwise for the ICU, I think it's also important to just go very slowly with the rehabilitation. Like you can't just, patients are, as David has said, their patients were like sedated for 10 days, and then you can't just go and sit them up. So you have to go slowly. So often we just went and we turned patients to their side. We waited for 10 minutes. We sat them up a little bit, and then we waited again for 10 minutes, and then we went to the side of the bed. So everything took a lot of time. Luckily, we had that. I'm a bit scared for the second wave, where we probably won't have that anymore.
Thank you, and that's a good point we'll come back to. Now, Rick, I want you to think back to March. And I was just having a chat with the panel before you joined about those very late night / early morning conference calls we were having to help co-produce the guideline. Now, in your experience, what we predicted back then, is that something you've seen in practice, and what's your experience over there?
Well, a little bit different from David's experience. We didn't have that much patients suffering from secretion problems. And surprisingly, we had very little patients also suffering from respiratory muscle weakness. So we had not that much patients that were on long-term mechanical ventilation with weaning failure. But we identified a large population of ICU-acquired weakness. More than 70% of our patients at wake up were weak, that improved at the time that they were discharged from the ICU to 50%, and still 25% of the patient had ICU acquired weakness at the time of hospital discharge. Although I have to say that those who were not ICU acquired weak in terms of the MRC also had a hand grip force that was approximately between 50 and 60%, so still weak. Similar to the experiences of the other colleagues, in the beginning were quite reluctant, and also in terms of availability of protective measures, we did not go into the ICU in the very early phase of the pandemic. That's quite different from our experiences now, because now we have similar numbers and even higher numbers in our ICUs, and we are now quite well equipped, both in terms of personnel as well as equipment, to deal very early now. And also the intensivists are more, let's say, feel more comfortable having us coming in. So that's a little bit different from what we had as experience in the first wave. The other thing that we actually did not consider in the guideline is something that came up when we had the first wave, that we really also considered how to move patients from being admitted to the hospital to be discharged from the hospital. So we had quite some good experiences, and we are close to publishing a paper on that, on pulmonary rehabilitation in a subgroup of patients who are able to follow an outpatient clinic. We had several patients who went for inpatient treatment, and as said before, several patients who were really candidates to be followed for pulmonary rehabilitation or rehabilitation anyhow did not like to be involved because they want to get home and not being involved anymore in any medical environment. But I think the guidelines were really helpful to support, and also in terms of the protection, that was really very helpful.
Definitely. Now you've touched on a really important point of pulmonary rehab there, because we certainly have a different consensus here in the UK, but I think it's really important to discuss. We already have a question on that as well. Ricardo, coming down to you.
Micro. Yeah, our reality was quite different from yours also, because we have here in Spain, we have a medical society that at the beginning almost forbade us to go to intensive care because we still depend on them. But there are several realities because just as you said, this is a country and we have small communities. And at our own hospital, we just started with treating these patients, these ICU patients, because I'm an ICU physiotherapist. At the very beginning, in the first 24 to 48 hours, we were already treating these patients. And as David said at the beginning, we just used the HME filters. So we have some problems with thick secretions. And sometimes nurses wanted a sample, and we were just able to take them with the physio, with the respiratory physiotherapy. Sorry, my English is a little bit rusty. But with the hyperinsufflation with a ventilator, and sometimes we were so needed of a sputum sample that even we applied the 0 PEEP. I know that it's a controversial technique, but sometimes we have used, and I've used them, and with good results. At least we got what we wanted. But the main idea is that here in Spain, my hospital was one of the first that allow us to treat them in between the first 24 to 48 hours. And nowadays, we are still there.
Thank you so much, Ricardo, and your English is perfect. So thank you.
I'm trying.
So Marlon, I'm coming to you next, then going to come to Sue and Amy. So please, can you share?
Oh, thank you very much. Yes, I can just tell that we have done pretty the same as the others. But so in Stockholm, we also, at the Karolinska, we also try to get the help from previous experience from the other countries and started to write our documents with guidelines at the hospital. And I think there were around like 120 beds at the ICU when we were at the highest rate. So we had to reallocate resources and expertise. So we have like a big physiotherapy department with all allied health professionals. So we were trying to reallocate so that we could cover up all the wards and ICUs and intermediaries wards also. And I think we played a very important role because we were doing all the education with the staff about the prone positioning. So we were like leading the prone positioning at the ICU. So I think we educated all staff at the Karolinska. So that was a very big mission we had. And we also, as Sabrina said, that we also started to work in 2 shifts in the evenings. also. We had never done that before, but we had to work that for a period of time. And we, as I said, we work a lot with the prone positioning to have a good ventilation on the patients, and also that we were involved in the extubation when there was a lot of secretions, and we had also experience of this thick secretion that was very hard to mobilize. So we had to use also a lot of airway clearance techniques. And then we also, of course, started to mobilize the patient out of bed. But rather fast, we call it like the step down to the intermediate wards, that they continued to have the mobilization and also the prone positioning and so on. And something we also did in Sweden, we started a national platform where we were sharing experience. It was both from the hospitals, the universities, and the professional associations, that we started to have like this shared documents. Everyone was very sharing, and that was very important. And we have like Zoom meetings every week to try to give some advice to each other and how we have worked. So I think and now we also in the recovery phase and preparing and in the second wave. So now we are followed after like 400 patients from the ICU in a follow-up multi-professional clinic. And so we are both the physicians and nurses and psychologists and physiotherapists and all the other allied health professionals. So that's very also exciting, and it's also a research project connected to that.
Thank you so much. That's really great. Thank you, Marlon. Sue, coming to you. Thanks for waiting patiently.
Oh, that's no problem. I mean, I have to say, you know, I'm just in awe of what people have gone through in the last 6 months. And I feel very fortunate that, you know, we've not had the same level of stress in Australia. Our experience is so limited compared to what the other panelists have got to give. So I'm just going to fill in some of the blanks that we'd had that others may not have. We also did the physio-led proning. We had a trigger to go to a 24-hour service because it was anticipated that we might move to one critical care nurse. We have a 1-to-1 ratio, but it was certainly projected that we'd go to 1-to-8. And therefore, I was on a committee for an ICU workforce preparedness we tour like the US, our health systems. We have a federal health system, but the states run the public health service. And so that was an ICU preparedness workforce committee. And it was interesting because once the barriers were removed that we all normally have to work in, people were much more open to the idea of working outside of scope. And that was, you know, a really worthwhile process, because it really showed that apart from being able to give drugs, trained ICU physios had the same level of skill as many as critical care nurses, particularly around scope of practice around things like taking blood gases, drains, etc., if they were credentialed in an appropriate fashion. So the scope of practice, I think, was an interesting process to go through. We experienced the same thing, that patients wanted to get out of hospital. People were quite desperate to get out of hospital. We are following up. We had a proning and a self-proning for patients who didn't get to ICU. They're being followed up at 6 to 8 weeks by a respiratory physician. We too are experiencing in the follow-up clinics this sort of persistent desaturation that's occurring. Most of our follow-up is done via telehealth, and the patients, the cognitive issues, even PTSD type issues are coming through quite early, much earlier than what we've experienced in our research where we followed patients up to 12 months. And and the other thing that I need to mention, because Anne Holland would shoot me if I didn't, is that the ATS ERS statement for pulmonary rehabilitation has just been published. But I think the really important part of it, as Michelle touched on for research, is it's got a core set of outcomes that are based on Dale Needham's core set. And I think if we are going to follow patients up, recording the same outcomes would be hugely beneficial for us to understand the trajectory of recovery. But I think also particularly the respiratory function, because that may be different to what we've experienced in other diseases. So that's really all. I think, you know, I defer to the far greater experience of the rest of the panel in terms of other physio interventions.
Thanks, Sue. And just a shout out, Sue, because it's ridiculously early over there. So thank you so much for having someone so esteemed on the panel as yourself at this time in the morning. You've touched on a couple of really important points, which were triggers in terms of when you move to 7-day 2-shift patterns, also when you escalate your staff as well, which I want to come back to, and the outcome measures in terms of not just when you start rehab, but in follow-up. And a lot of the normal, if you like, functional exercise tests we'd use with patients were really limited. Well, certainly we are in the UK. You know, that's a question I'll ask everyone after I've been to Amy about how we manage that in terms of infection control, but also having a, you know, functional outcome measure that we can use. So thanks, Sue. Amy, coming down to you, last but not least.
I'd like to commend my colleagues here today for all the work that you've done. And certainly the early work that came out from all of your experience was super helpful for us in the States who were lagged behind everybody else as far as our infectivity rate. We actually do know that we did now have infections probably earlier than we initially had thought, even early on through January. So I think we probably had some cases come through without necessarily knowing about it at that time. But just to give you a bit of an idea, again, I started pulling up some of the data that we have from Duke. Duke has put together different dashboards, which has been helpful to track infectivity rates. What are the hospitalizations like? How long are people staying in ICU? And this is all available to us as clinicians. And then how many patients do we have at any one time throughout the hospital stay? Because like I said, we don't have one dedicated unit, they are spread throughout. And actually one thing I will say about Duke is we are also a university hospital system. So there are actually 3 hospitals. There's a more community hospital, there's another hospital about a half hour away from us, and there's the Duke main hospital, which is the tertiary care center. So we would get different patients from there coming in. Now, a little bit different thing about the US, and you've all touched on all these great things, so I won't repeat what folks have said here as far as practice goes, but in the US, we do have multidisciplinary teams, and it is the respiratory therapists that are responsible for doing the medications for airways, also doing the ventilators, managing the ventilators. And so PT works closely with the respiratory therapists. And so we are still responsible for doing the airway clearance techniques and doing the positioning, including helping with the proning. But as far as the management of the intubated patient, that comes down to mostly the respiratory therapist. And then once the patient we also then have algorithms and different teams that will treat patients at different parts of severity and recovery. So we have an ICU team of dedicated therapists, and once they're on the unit, they stay on the unit for the day. The same thing with our step down units for both recovery and also for mild stages where people are coming out of COVID. So we have 2 different units there, and 2 different teams are deployed to that just cover those patients. And again, they stay on the unit so that we're not having intermixing elsewhere in the hospital. Duke developed a nice way to actually salvage our N95s. And this was a big concern for us early on, is would we have the PPE necessary for our therapists? So initially therapists were staying out of the rooms, communicating with nurses. And if they had to go in, they would then suit up. So now we have deployed teams that are going there, and they have it worked out. But initially, that was a big concern, and Duke developed a way to salvage the N95s and clean them so that we could have more PPE on hand and get the therapists into the rooms. We also are working with a core set of outcomes. So thanks for mentioning that, Sue. We're trying to do the same here and have that data be readily available for our COVID patients. And I was part of a team that actually wrote a small grant to our association to be able to helpfully get some of the statistics on the data that we're all collecting. But Duke is a research center, so I can't necessarily talk about clinical care without talking about research. So all these COVID patients are being followed by multiple protocols, some of which I'm involved in. Some are focusing more on the respiratory outcomes, some are focusing more on the cardiovascular outcomes. We're actually doing one study I'm involved in, doing metabolic testing on the patients and correlating that with recovery outcomes. So if we have time to talk about that, I'm happy to add more information, but that's what's happening here in the States, of this partitioning of which disciplines are taking care of which aspect of the patient.
Yeah, we in the UK we get that a lot, actually, comparisons between respiratory therapists and in other countries. So thank you, everyone. I've just found that fascinating. I'm scribbling away. I want to just come back to a couple of people on different points. We have tons of questions as well, which we will get through, everyone. And just so you know, I've posted the papers and the guidelines in the YouTube chat that we've just talked about. Sue, can I come back to you? Lots of questions around the shift patterns and triggers. So can you just, I'm gonna talk first about staff preparation, and if you could tell us about, with reference to how we're now planning for second, third waves, heaven forbid, fourth waves, with reference to how you answer that question. Thanks.
I think one of the key things which others have touched on is identifying the resources that you have across your whole service, clinical service, and making the best use of those to manage. So we stopped doing elective surgery, which freed up a lot of our therapists, which enabled us to skill up. You know, we had subacute services that we skilled up to do pulmonary rehabilitation in many cases, thinking that the patients may end up in subacute, and these people wouldn't have seen a respiratory patient in years. So it enabled us to, we had time because we were delayed compared to other countries. So it enabled us to skill up where appropriate and identify the resources that we needed. And so we had a trigger in our ICU that when we had 6 ventilated patients that we would trigger from. So our normal service is a 12-hour service, and it triggered to a 24-hour service when that happened. And as I said, the physios led the proning with the assistants. So there was always, there was going to be an anaesthetic registrar on hand for when the physios needed someone to come in and manage the tube in the setting that they wouldn't be turning the patient prone with necessarily any trained ICU staff, that it may be a whole, a group of people who weren't used to ICU, therefore that we needed someone with expertise to manage the tube. The other thing that was unique was that we developed these interdisciplinary practitioners across allied health that could deliver allied health screening and allied health interventions, which reduced the volume of exposure of the allied health staff. We didn't have huge concerns. At the start, there was a concern, but I don't think it was as significant as the international concerns around the availability of PPE. We too, as Amy alluded to, found ways of recycling the masks, and that gave people a lot of confidence that there was sufficient PPE around. And although we have, people may have seen or may not have seen in the press, there's quite a lot of healthcare worker concern, particularly in Melbourne, but that wasn't actually related to PPE. That was related to the spaces that people were having breaks in and infecting in that way rather than the failure of PPE. So I think, it was about identifying what tasks. I think, we sort of have these empiric ideas of what a nurse does and what a physio does and what all the other technical aspects of care. It was about unpacking what are those tasks and what is the credentialing that's required for each of those tasks and who is best placed to do those tasks in terms of availability. So that's really how we got to the point of elevating the physios out of their normal scope of practice within the ICU.
No, and I think the great point you've raised there and you've articulated is being prepared rather than reactive. Now, David, I'm going to come into you, because in the first wave in the UK, we were preparing, and we had what we thought was 2 or 3 weeks, and then within 2 or 3 days, so David's unit in particular went from 19 ventilated patients or something to like nearly 100 in 2 days. And in London, we seen that. In the peripheries, we didn't so much, but we definitely reacted, David, didn't we? We shut everything down, everything got cancelled, everyone got redeployed. Now, in the second wave, what's your advice for second wave, David? Now we've learned from, I think, what was an appropriate reaction to have at the time, but now we've learned from that. What would your advice be?
Yeah, I think that question raises 2 points. The first one is, last time we were way ahead of the curve, even though the curve got very steep very quickly. We closed outpatient departments, we cancelled elective activity, we freed up a significant number of therapists, we spent time training staff to be ready for what was coming. And it meant when it hit, we were prepared. There were areas of the ICU that was empty, it was spring, there were less pressures on the service. And I think moving into phase 2 or wave 2, we know that all these things are still running. There's the normal winter pressures that are hitting the hospitals anyway. There's a reluctance to close outpatient departments and cancel elective activity when there's already such a significant backlog. That therefore means there's less staff available, and that's before we then consider the burnt out, worn out, don't want to come back staff. So I think there's different challenges anyway, which is going to make this slightly different. I think the things we did learn, though, I think last time we went at this with a very blunt instrument, we saw a huge amount of patients coming, and I think we almost treated it like it was going to be a major incident war zone, and we threw everything into ITU, into the wards. And what that meant was we redeployed a lot of therapists into critical care, and we categorized everybody into either you can work on ITU or you can look after really sick respiratory patients on the wards, and that was it. And what we realized about halfway through that process is, as these patients were coming out with quite significant rehabilitation needs, our upper limb therapists were filling bed spaces on ICU, our neuro specialist staff were working in different areas of the hospital, and we just didn't have the rehab provision in place to actually manage what was coming out. So I think future waves, we need to address that a little bit more. We need to be more prepared to receive quite high acute rehab patients coming through the system. We need to make sure we're maintaining the integrity of therapy services and not just being redeployed for the additional roles, although I think that did work really well to support the intensive care staffing, but just to have much more seamless pathways in place to get people off ITU onto the wards, but then have appropriate provision in the community as well to keep managing those needs as they move forwards, but also thinking about the well-being of staff and the support of staff who are coming through. So if there's the capacity to rotate people through the COVID ICU and the non-COVID areas, give them a break from actually what they're being exposed to, and make sure we have much better support systems in place as well. So there are some really good pieces of work coming out nationally and internationally. The European Society of Intensive Care Medicine have got a huge training program for non-critical care staff, which is free to access. I think that's just gone live, so we can start to utilize that international training to support non-ICU staff as well. So I think there's a lot more resources that we can tap into, but certainly in the UK at the minute, it feels a little bit like we're not as well prepared as we were last time, and perhaps we're going to end up in a bit of a reactive state as well. So we just need to keep making sure we're championing for our staff and pushing this forwards from our side.
Thanks, David. Now, I've got a question here about proning, and Marlon, I don't know if you want to answer this or anyone else jump in as well. So there's a couple of questions around increasing compliance for the prone position for both the ventilated and non-ventilated patients. And again, if I speak from some of the experience of our colleagues, the awake proning was very successful in a cohort of patients who were, incredibly oxygen dependent. So can you answer that question from both a invasively ventilated patient and a patient on either oxygen or, high flow oxygen device?
Yes, I can try to start. Yes, so we were actually also trying rather early to be like start with the active prone positioning with the awake patient. and to do that before they got to the ICU, and we start to have like protocols to follow the saturation and all the other symptoms, the patients, and the breathlessness and dyspnea and so on. So I think we now, if when we are preparing for the second wave, we will start earlier with the active prone positioning, and the patients tolerated it rather well, and we had they had to stay in that position for as long as they could. And I know there are some projects going on now with more detailed protocols of how we're going to do that. And also at the ICU, we were doing that and tried to have like for 16 hours, and we were like 5 staff, like 4 maybe to do the proning, and also a physician to check the tube, of course. I don't know if that was the answer of one of your questions, maybe. And also to check, of course, the PFI and so on to see that the patient were tolerated.
Yeah, and then it was in the non-ventilated patient as well. In terms of is it something that you tried with every patient that didn't require mechanical ventilation, that was just hypoxemic, holding their own with oxygen therapy? Or did you select specific patients to use awake proning with?
Yeah, I think there were some kind of selection from my colleagues, actually, that the patient could to do that active positioning as well, because if they had some other problems, maybe you had to be a bit aware if they could do the proning, actually. So there were some kind of selection, but I don't know all the details around that. So maybe someone else maybe have a better answer on that.
And I can definitely post some protocols that we have in the YouTube chat. That's no problem at all for conscious, we call it conscious proning or awake proning. That brings us on nicely to respiratory therapies for the non-ventilated patients. I'm going to come back to rehab in a moment, but there's a couple of questions that I'm going to combine with, did anyone use any respiratory adjuncts? So for example, PEP or intermittent positive pressure with these patients, was it needed? What did people find? Does anyone want to come in with that and talk about their experiences? Or did people generally not use any devices? I don't think we used a lot of devices at all in the UK. We used a lot of hands-on techniques, much more than in positioning and then functional rather than devices. There was a mixture of reasons for that. That was because of infection prevention control and the risk of increased aerosol generation, even though these patients were technically in red zones, like COVID managed zones. But Sabrina, I can come down to you. What was your experience?
Well, we, same as you, we didn't use it that much. We used bubble PEP and PEPs a bit from time to time if they managed to clear their secretions. But as I said, we often used hands-on techniques like the active cycle of breathing to learn the controlled breathing, and use the different techniques as or positioning, like in a side position with a stretch over the arm, or also proning or assisted proning and for the awake patients. Maybe I can also elaborate on our terms. We usually ask the patients, can they do it themselves? Mm-hmm. And mm-hmm. if they couldn't, sometimes we helped. We just, if they could turn on their side, we put a large pillow or a duvet, like we call a large pillow, just in front, and then you just go a little forward, and we call that 135 degrees prone. And in this position, again, we did the respiratory exercises. And we also saw a lot of improvements in oxygenation with that. Yeah. What we did in a few selected patients was inspiratory muscle training after the ICU. So that was mostly tracheotomized patients that was one of the I think, yeah, bubble bath and respiratory muscle training.
We do have a couple of questions about respiratory muscle training, but I was very nervous about bringing it up because Rick might then talk for the next 45 minutes. So Ricardo, I'm going to come down to you, but first, Rick, can I come to you because we have 2 or 3 questions about the role of respiratory muscle training in critical care and beyond for COVID-19 patients. Your thoughts, unbiased thoughts.
No. Well, biased in a way that we expected actually quite some patients also suffering from respiratory muscle weakness, seeing the high number of patients with ICU acquired weakness. But I've spoken to colleagues and friends in Paris, the group of the Moule and Dres, and actually they have the same experience that a very limited number of patients were suffering from respiratory muscle weakness, which is quite surprisingly given the fact that these patients are provided with quite some long period of sedation. The level of ventilatory support might also be one of the factors that is involved in diaphragm dysfunction. So actually we had, I think I can count them on one hand, I think we had 4 or 5 patients out of almost 130 patients that were in the ICU on mechanical ventilation that in the later phase had weaning problems and went into inspiratory muscle training. So it was really a very minor proportion of patients that were suffering from that.
Thank you. I think that's definitely our experience as well and what we've heard from colleagues. So thank you, Rick. Ricardo, coming down to you for your thoughts. Thank you.
Yeah, just a small one. The awakening process of these people in intensive care sometimes is quite hard. So, and as they have a lot of cough and a lot of work, so probably a little bit of that could help. That's why I asked before to speak a little bit. It's just because at least we try to use the PEEP devices with a 10 to 12 of pressure to avoid go until the end of the expiration, because some of them have a lot of cough. So try to keep the breathing, the active cycle of breathing, or even sometimes with some slow expiratory techniques with these kind of devices really helped to mobilize air, and if there were some secretions to try to keep them and avoid this cough that it's so problematic, at least in these patients. That was just a small thought.
Thank you. No, that's really helpful. And you've brought us on to the next topic area, which is around strategies. So you've mentioned some strategies to help with the respiratory therapy, but also lots of questions on anything that's potentially prevented intubation. Now, from a respiratory therapy point of view, physiotherapy, I'd like to ask the panel if they had any magic gems or secrets. From what we found in the UK and speaking to our counterparts is actually it's a combination of medical therapy, oxygen therapy, positioning. The use of high flow nasal oxygen therapy is controversial. For those asking about research, for those asking about is it an AJP or not, Fisher and Paykel have the most incredible webinars which have international panels on them. Please go and view their series of webinars that are all about high flow nasal cannula, and the most recent one is all about AJP generation, so please go and visit them. So that's the question for the panel. David, coming into you, and anyone else give us a wave that wants to come in.
I think probably one of the things to add in is, I think last time there were early reports that potentially CPAP and high flow just delayed intubation, actually led to poorer outcomes. And I think certainly at the beginning of the first wave, we were very quick to intubate, and nobody came to our intensive care unless they were intubated. So the other people were staying on the wards. I think this time round, I think the later evidence coming out of Italy was actually they were using CPAP quite a lot. I don't know if that's because they were running out of ventilators or space, but actually that was working quite successfully. So we've had a number of patients now coming to ITU on either high flow nasal oxygen or CPAP with awake proning, and certainly then haven't led to intubation in quite a significant number of those cases. So I think there's a change in kind of attitude that if we can avoid intubation now, it's much, much better for the patients. And some of them are doing very, very well with that approach.
Yeah, and the bottom line from the Fisher and Paykel webinar series is that high flow oxygen is very, very safe. There's very low risk of aerosol spread, but we should still use full/enhanced PPE when those patients are on it. So just to save you like 4 hours of watching, that's the bottom line there. Sorry, just quickly going to, so I'm going to move on to rehab and then I'm going to come back to the non-ventilated patients. Lots of questions, some of them are triggered by the discussion around knowing what we know now, what outcome measures should we be starting in the ICU for COVID-19 patients that can be followed through for discharge, so knowing what we know now. Michelle, can I come to you first, and then anyone else give us a wave who wants to come in on this? Sue, maybe coming to you next.
Sure, I think there's some really great work that we can build on that's already existing by our ICU colleagues. I think one of the things that could be the easiest thing to initially incorporate in terms of outcome measures is the ICU mobility scale. So it's something that we could easily generate from the chart. It's something that can be done across disciplines and can also allow us to track the trajectory of patients across their hospital stay. So it starts at 0 with passive movement, going all the way up to walking independently. And I think that starts to get at some of the things that are important to patients. From a practical perspective, if we're starting to see patients in the ICU being able to move from sitting to standing, I would suggest the 30-second sit to stand, because it's only 30 seconds. It is something that, again, is functional, but also has age and sex match norms that could be tracked over time. And then we could also look at comparative literature.
Thank you. And that's definitely something that we're doing over here due to the restrictions of things like the 6-minute walk test, the incremental shuttle test. Now, there is some questions as well, specifically for you, Michelle, around the use of in-bed cycling.
Sure.
And also about when is early rehab, when is too early? David, I mean, you're probably laughing here because this is a question you get asked all the time, probably the same for some of the other colleagues, but if you could answer the cycle question and then I'll maybe answer that one and I'll come round to anyone else.
Sure. So we're currently leading an international trial of in-bed cycling with critically ill patients. And, you know, Sue and Amy are our dear collaborators as part of this trial. And part of our approach was thinking practically about the physiotherapist's time and need to decontaminate the in-bed cycle. So once the pandemic hit, we actually had our research on pause for enrolling into the study. And I think we have, I believe in Sabrina's case series, there was some reports of in-bed cycling. And I think this is going to need to be a sort of cost benefit, considering the amount of rehabilitation time you have, the equipment available, and the things that we think are most pressing for patients right now.
Thank you. Sabrina.
Yeah, I have just to say something about cycling as well. Thank you, Michelle. We described one example of cycling in our case series, which was a very weak patient. We were lucky because we have 2 bed cycles in our ICU. We have 30 beds, and we used one bike for the COVID patients, and the other bike was used for the other patients. So we were just 50-50 with COVID and non-COVID. So it turned out very well. So we just used that one cycle for the COVID patients. We cleaned it, of course, between each patient, and the other other cycling was used for just non-patients. Otherwise, we use the same criteria as we would use in other patients. Maybe they're too weak yet to sit up, or just as an adjunct in the evening to do something else. If they're too tired to sit up or something like that would be indications, in my opinion.
Thank you. Now, Sue, coming to you for your opinions and generally about rehabs. There's a lot of questions around people being fearful for starting rehabilitation in that very post acute phase, like the post ICU phase, because patients are exhausted. They have these cognitive impairments, deficits. They have the whole psychological trauma of waking up knowing they've had COVID and they've been ventilated. And like David said, the whole everyone's in PPE. So what advice do you have for people out there who are just starting to see their ICU patients emerging and they're fearful of starting rehab?
I think starting rehab when they're in the ICU is almost the safest place for them to start, because you've actually got the best monitoring. And I commend, David's experience of being able to do that before they go to the ward. I think gives the ward staff so much more confidence in terms of how patients will react to physical activity and movement. And I think that's actually a really important, that part is really important for the ward-based therapist, particularly if you've had to consolidate a lot of your high-end skill into the ICU to manage numbers. I would completely concur with what David said. One of the things that we tried to do for the COVID patients who were on our wards was that we actually had an ICU trained therapist doing their rehab. We had some more monitoring than what was usual available because of the respiratory nature of the disease. So really it became a respiratory HDU. But I think the problem is I'm empathetic to the fear, particularly if that's not in your experience. But the most important thing is to be able to get the patients out of the hospital bed and out of the hospital altogether. It reduces their risk, particularly, I mean, I think we have situations where people remain COVID positive for prolonged periods, but I think that's the minority of the patients. Most of the patients that we had were COVID negative by the time they left hospital. But getting them to the point where they can leave hospital safely and can be managed, we were, I think one of the things that COVID did do is that lots of people were working from home, which actually increased the capacity of families to look after patients who were perhaps more marginal than what they normally would. But I think that's one of the big step up roles that we have in this space is to provide the leadership in the rehab and give the confidence to the families that these patients can be managed at home, and we really need to look at follow-up services for these patients that can occur either in their homes or in their communities to try and help with families manage the cognitive load. I think access to neuropsychs and psychologists is really important. We also had, Melbourne's very multicultural, and one of our big challenges has been reaching into all of the different multicultural areas, and indeed that's why we got one of our second waves. So I think that cultural awareness and access to interpreters so that the information and education is really clear. To me, the rehabilitation, the breathlessness is a really significant problem. And I think that's something that we used to be a lot more experienced in managing, and perhaps certainly in Australia, because smoking has gone down so much, so we don't see a lot of the really acute breathlessness that we perhaps did 20 years ago. So I think that's probably been the biggest challenge for us to manage in an ongoing fashion is managing the breathlessness and giving advice to patients and families about that.
Yeah, I would concur. I think the ongoing breathlessness and fatigue has been overwhelming factors in the post-acute phase, and for what we're probably coining as the long COVID syndrome, which includes those people not hospitalized. Now, there's lots of questions around respiratory muscle weakness and breathlessness, and certainly I can speak for the UK, we can't say it's respiratory muscle weakness because I think in general we're just not measuring respiratory muscle strength. We're not doing spirometry, we're not doing tests, but what we're saying is unexplained breathlessness. We're probably linking it into post-viral fatigue syndrome. We're probably linking it into deconditioning and global muscle weakness. But really, I think I don't know, David, just nod or shake your head if you would agree with that. I think that's kind of where we're at now. Michelle, I can see your hand up, and I just want to come round to anyone else as well for comments about that and what they think.
I've got a comment actually related to Sue and family, so I'm happy to come back to that after we answer this question.
Okay, no problem. Marlon, I see you.
Yes, we are following. I don't know if you now mean in the most acute phase, but now when we are following them, like after 6 weeks, 6 to 8 weeks, we see that they have like a decrease in the inspiratory muscle strength. Almost everyone from the ICU, actually. And also the lung function has decreased, and the overall muscle weakness, of course, with the chair stance test and so on. So we are following them now, and we also have tried now with the inspiratory muscle training for those now in the rehabilitation phase. And they also have this experience of like a what you say, a band like around the chest, pressure on the afterwards, and this fatigue and the cognitive dysfunction and the cardiovascular, the heart frequency has also been a lot of variation. So that is what we see now, but that's like after 6 to 8 weeks.
Definitely, and it's a strange physiology in the presentation of that, but it's consistent. And I think this is why the long COVID definition we're really working on in the UK at the moment to define that and understand that more physiologically and what that means. David, coming into you, then Michelle, I'll come to you for your comment.
Yeah, I think it ties in with the question you asked about early rehab and when is early and when should you start. And I think what we were able to find quite nicely is everybody pretty much moved within 24 hours of sedation stopping. Well, and it was about 5 days before they were liberated from the vent. So they were still very much in acute phase, sometimes on hemofiltration, sometimes receiving inotropes. But I think what we learned along the way was these people that had quite high respiratory rates that normally would make you nervous or preclude rehab, even if we turned up oxygen and turned up respiratory support, the rate didn't particularly change. And as we started to rehab them, again, the rates weren't particularly changing or actually even coming down. So there seemed to be something else driving that breathlessness, whether that was something central, it's something we don't truly understand, and it's something that certainly persisted throughout the recovery. And we did actually find that we had quite a number of patients who went from pressure support straight to trachea mask and were actually a lot better once we just got them off the ventilator. Mm-hmm. So it's something we don't really understand, but I would say to people that don't make that a limitation, just assess slowly, sit patients up, start to get them moving, and actually you'll probably see very little change in that breathlessness, or certainly no desaturation over and above what they're doing anyway.
Absolutely agree with that. And Bronwyn Connolly's just put a note in the chat and a link to the COVID core outcome set. So thanks for that, Bronwyn. I'll just make sure the link's up there. So I'm going to consolidate. Michelle, sorry, coming to you for your comment.
Sure. I'd like to build on just briefly on Sue's comment in families. I think that we have a lot of knowledge from following ICU survivors that exists in the ICU community, and that patients with COVID are probably somewhat similar, despite some of the differences that we're already hearing. So in terms of ICU survivorship, I think if we're thinking about family members, we also need to consider what the potential impact of reduced visitation policies in the ICU has had on both patients, but also on family members, because we know that with post-intensive care syndrome, that family members and caregivers of patients in the ICU are at risk of important psychological distress. So it's something that we as physios could perhaps communicate to the team members, but also to patients and their families to understand that what they've gone through has been so traumatic, and that when we have the follow-up clinics, not only do we consider the health of the survivors, but also for the family members.
Yes, thank you. I totally agree. Thanks for your comments. Now, I'm going to consolidate some questions here and make some statements. So if anyone likes to add in or disagree, please do. So there's a question about, did we see high incidence of neuromuscular patients being admitted in the intensive care unit with COVID-19? The answer is, in our experience, no, we didn't see like ALS patients, we didn't see Duchenne's patients, we didn't see, those with, long-term chronic neuromuscular conditions. We just didn't see that. Probably because they've been shielding since December. That would be our guess, and because their infection prevention control is really good. So I would say no. Okay, I can't see anyone disagreeing. Tracheostomies, no, yes, Amy, go for it. Yeah.
It's hard to speak for the whole US here, but I think there were disparities across the states of those patients coming in. Oftentimes some of those folks with those diseases and conditions are skilled nursing facilities, which got really hit hard here during COVID.
Thank you, Amy. That's an important point actually about different setups, isn't it? Thank you. Tracheostomies, we all thought we weren't going to see trachees in COVID-19 patients. Actually, in the UK, we used trachees a lot in the more inappropriate patients and had a very high survival rate and very successful weans. Like David said, as soon as the trachees got out, we seen, as soon as they were awake and, their oxygen requirements were low enough to be awake, the decannulation phase. In the majority, not complete patients, we've seen lots of upper airway edema, lots of laryngeal dysfunctions. Speech and language therapists have been very busy in intensive care, but as a rule, yes, tracheostomy was an effective modality to aid ventilatory weaning in COVID-19 patients. I'm just looking around. Okay, great. So this is a question, and this is, if anyone would like to answer it, in terms of, the use of adjuncts hasn't really been necessitated in first wave or first-hand experiences, but now we know about the secretion problems of patients. Would an oscillatory like PEP device or therapy seem like it should be something we should be considering for those patients, knowing what we know now? Marlon, I can see you're nodding furiously there, so I'm coming to you first for your opinion.
No, but I think that's important now because to do this individual assessment of the patient and to choose the right device. I know that my colleagues are doing that all the time, and that it could be like the PEP or the NIV or also the cough assist. They also have used for those with very weak muscles. So I think in the beginning we were a bit careful, but now we are more prepared and know what to choose after, of course, an individual assessment.
No, I completely agree. And I think the pragmatic approach is to have your devices and have all of your tools. Now we know what we know about aerosol spread, infection control. It's have them in your toolbox. And nothing we would ever do would be just because or matter of fact. But I think if we feel like it's going to work. And give it a go for sure. Okay, anyone else have any questions about that? Okay, manual hyperinflation. Did people use bagging a lot, manual hyperinflation or ventilator hyperinflation in the patient group? I can see Sabrina shaking her head. David, do you want to come in? Ricardo, then I'll come to you.
Certainly not manual hyperinflation. I think there were lots of nervousness around disconnection of circuits, the pressures that would be used and the lack of control. Where it allowed us to, with space for peak pressure, we often had patients ventilated at peak pressures we wouldn't want to go above anyway, but where there was some leeway, we used VHI really quite effectively. Again, particularly with those with thick and tenacious secretions. So I think there's more of a role for VHI than we thought there would be initially. But it's a certain group of patients where you have that flexibility.
Thank you. Ricardo, coming down to you. Is your experience the same?
Yes, yes. Oh, sorry. Is this open? Yes, yes, it is. Yes. We at the beginning we had a lot of scare. We were scared of all kind of intervention, but we did a lot of ventilator insufflation, and because there were some limitations with the personal protection equipment, sometimes the physio did the P01 measures and including the leak. How do you say that this in English? The leak test? No,
yeah, that's right.
Yeah, it's a kind of no.
Yes, that's right.
The physio was sometimes the one that gave that kind of info to the team, because at the beginning when corticosteroids were said that they were not the best intervention, we didn't use them so much, and we had a lot of edema. I don't know if this was your experience, but that's why I was waving before.
Yeah, no, that's a really important point. It was unexpected, and I think we started to look for it in some of the high-risk patients, and yes, the cuff leak tests were performed in some of those high-risk patients for sure. Okay, and I'm just looking around to see if anyone so just trying to consolidate a couple more questions here. Nebulization. So some of the Mexico teams are on saying that they just don't use it at all. Did we find nebulization beneficial for this patient group? We definitely avoided it in the height of our pandemic. Has anyone got any strong opinions on nebulization for intubated and non-intubated patients in COVID-19? No, I think, we didn't do it routinely. We didn't for lots of different reasons, like David said, disconnecting the circuits, what would be the added benefit? And we tend to use installation of normal saline to help clear secretions with lots of manual techniques and positioning. Again, there's still quite a few questions about intensity of exercise. So in terms of how intensive exercise should be, I think this is such a difficult question to ask. In terms of Sue, you mentioned desaturation and these hypoxic patients. So, should we is it breathlessness we should be monitoring? Is it saturations we should be monitoring? This is going to move us on to the pulmonary rehab discussion about whether it should be individual based exercise prescription for these patients, or whether group activity and rehab might be an option. So Sue, I'll come into you first, and then Rick, maybe coming down to you, because I think you mentioned PR first, and then anyone else. Thanks, Sue.
Well, I would actually defer to the experience of others in the panel. I mean, we've had such a small group to really work with. We're seeing them individually through telehealth, which is enabling very prescriptive exercise, for the person. We have been doing 6-minute walk tests because they come in to see the doctor in the respiratory clinic. So we're certainly basing intensity off that. But I think there are many people here that would have vast more experience that I would defer to because we just simply haven't had the experience of it. So I think Rick would be in a much better position to speak to this than I.
Okay, Rick, I'll come down to you, and then Marlon, I'll come into you. Thanks, Rick.
Well, referring to the patients who were admitted to a pulmonary rehabilitation program after discharge, we had quite a few people that were still severely desaturating during exercise. So like we do in other patients with respiratory disease, we titrate them with oxygen. And over the 3 to 6 months that we are now following those patients, actually all of them are now without oxygen. So their diffusion capacity almost returned to normal values. And in terms of intensity, we follow the same, let's say, rules. We do exercise testing prior to the rehab program. So we have a maximal exercise test. We have a 6-minute walking. we do muscle testing, and based upon these results, we titrate the intensity like we do for, let's say, patients after transplantation, COPD. So actually there was not too many differences except for the desaturation, and let's say different from, let's say, other respiratory populations where there's no change in diffusion capacity over the term of a rehab program. We were surprised that all of the patients who were on oxygen by the time that they were discharged had no oxygen needed anymore. And maybe for the intensive care, for the early intervention, like David was mentioning, we have to remember that in the early phase, patients are doing some cycling, for example, bed cycling. And if you go back to physiological responses to this low intensity exercise, there's actually no change in oxygen saturation, not in heart rate, not in ventilation. So it's really something that is really, let's say, not affecting too much the cardiorespiratory system. It's maybe a little bit loading the muscle, but not too much affecting the cardiovascular and respiratory system. So we start early with cycling.
Thank you, Rick. Marlon.
Yes, we have had, as I said, there have been many patients that have recovered afterwards, but also some that we also find new symptoms, and the 6-minute walk test have been very good test to really detect those various symptoms, because some patients that have been rather good in the oxygenation has desaturated during the 6 minutes walk, and also the heart frequency has been, as I said before, very various in some patients. So that has been important to detect those who really need the more specialized pulmonary rehabilitation. And we have also used a lot of this Boris scale to rate their breathlessness and also the fatigue in the legs and so. And also try to teach the patients how they can rate their own symptoms in according when they're doing their exercise. So some of the patients are, of course, they have recovered and they have managed their own exercise, and there are a lot of patients also training in the primary care. In Sweden, we have that system. But some of the patients that we are having in our own outpatient clinic and do a lot of assessments, but they have a lot of various symptoms and also a lot of cognitive dysfunction as well. So the whole multi-professional team around them.
Thank you. And there's a couple of questions about Amy, coming down to you.
Just a quick comment. So I would say some of our stages of recovery have different frequencies and dosing. So in the hospital, we've recently looked at changing our practice for COVID patients to increase the frequency to accommodate the levels of fatigue. We do have coverage 7 days a week for physical therapy as well as occupational therapy. And oftentimes patients would be prioritized on the weekend for severity and potential for rehab. But we're thinking about doing something different now where patients with COVID would get more frequent treatment at shorter intervals. And then once they leave the hospital, similar to what Rick described for outpatient pulmonary, we are doing. So it's individualized exercise prescription for our pulmonary rehab, but we do a month-long program. So it's a 5-day-a-week program for a month. And then there's also potential for maintenance there. Some other approaches that we're thinking about using, and we actually wrote a grant on this, was to use high intensity interval training for those that are leaving the hospital and able to go home, and to do this via telehealth kind of basis so we can reach more people. So those are my comments. And also actually in the hospital, we have, particularly in the ICUs, we have beds that can come to a chair position. So we've allowed a lot more patients to sit because we don't have to get them out of bed to do that. So thanks.
Thanks, Amy. And can I ask if you're recording spirometry or lung function on your patients, and if you're seeing any changes compared to their, predicted for their demographic, like age, weight, height, sex?
We haven't been doing routine testing.
Has anybody been doing routine? So Marlon, I'll come to you first, then Rick. Have you seen any differences? A lot of questions about that.
Yes, yeah, we have tested all now after 6 to 8 weeks after, and yeah, some have a normal lung function, but there are some who have a decreased lung function and also a restrictive lung function afterwards. We see that in many patients, but some have rather normal. But so I can't say any numbers, but we see a various of how much they have decreased or if they are normal.
Thank you. And Rick?
Well, the patients that we are following in our rehab program, we follow them now for 6 months. And surprisingly, those patients on average do have almost normal values for pulmonary function. So it's surprisingly, and again, also for diffusion capacity, they were quite well recovered, although the majority of these patients were admitted to the ICU for a while. So we're really looking into a more sick population. Mm-hmm. And surprisingly, they also on CT scans, we were surprised by the change that we observed from the CT scan from the ICU until the CT scan, even up to 6 weeks after discharge.
Thank you.
Really a different pattern.
Thank you. That's so interesting. I've got a little bit of a random question going back to ICU about, is anyone measuring lactate during mobilization for COVID-19 patients? No. No, thank you.
For those that are in our research protocols, we are, but for those outside the research protocols, it's not routine.
Thank you. And I'm very conscious of time. We're over on by 8 minutes now. But there's just a couple of questions left actually about CPAP weaning. Now we use CPAP, I say a lot in some of our centres. We used high flow more. In terms of weaning from CPAP, the question is, did we find patients were requiring oxygen therapy for a long time once removing the PEEP? It was varied in our experience, and there was sometimes little correlation between the initial presentation or severity. Like David said, our initial strategy was to intubate rather than use non-invasive devices. What is everyone's thoughts on that? So did it take a long time to wean PEEP for those patients that were managed with CPAP therapy? And when we did wean it, were they on oxygen for a long time? Or is it just really varied? Varied? Yep. Now the last bit is around COVID-19 patients in the community. What interventions, what advice do you have for therapists in the community treating COVID positive patients, knowing what we know now? What would be the interventions that you would say as physiotherapists, what we should be doing with these patients, knowing what we know about potential long COVID, etc.? So these are for COVID positive patients in the community. Anyone want to jump in?
I'll have a go. I think it's a question we're all still asking. I think we're trying to define what the best interventions are. I think if we look at things very simplistic, we would say exercise, pacing, energy conservation, anxiety management, nutritional advice, psychological support. We know, particularly with the survivors coming out of hospital, and particularly in intensive care, there's a huge psychological burden around. There's almost a survivorship guilt that comes with, often there's people they know, family members, friends, and that's having an impact. But I think there's ongoing investigations. There's a couple of big trials that are looking at what's the best way to manage these patients. And I'm sure there's a combination of exercise and behavioural interventions that will work. But I think it's making sure it's that holistic approach. You've got the whole MDT involved. It's not about one profession or just exercise. There's a lot more to this, is all I could say so far.
I would agree with that. I can see lots of nods. Okay, so we're going to start tying up now, and I would really like to give the panel an opportunity just to say any final thoughts, words of wisdom, whatever it is you would like to finish on. I like people to have the last word. So I'm going to go role reversal this time. So Sue, you'll be last. You've got more time. So Marlon, can I come to you first, please?
Okay, yes, but I totally agree with David. I think that is very good point to have this holistic view in the whole rehabilitation for these patients, and also that not only the patients at the ICU, we're also following the patient at the other wards, and also the one from the community, the primary care that has never been in the hospital, have also a lot of symptoms. So I think we have to be very curious and really follow these patients and try to learn from each other, so we can take care of them, to assist them and to rehabilitate them well.
Thank you. Sabrina?
Well, I would agree with that. I would also add that we should screen and assess. We should do the basics right, and that teamwork is the key to survivorship. So physios are very important to the treatment of COVID.
Thank you, definitely. Ricardo?
We are in a fight here in Spain. We are still trying to get in the ICU in the first stages. So the only thing that I can say is that we will keep trying. We will keep fighting to put our profession in the right place here. We are fighting, and the knowledge of all of you is thankful. And thank you.
Thank you, Ricardo. Michelle?
I'm actually going to quote Jack Awashina, who says, the team. Continue to support each other and be kind to each other, and try to think about how we can help each other both locally and internationally.
And thank you. Aren't you doing that right now, Michelle? So thank you so much. Rick?
Well, I think one of the things that that put the emphasis on the patient population who is surviving critical illness, and specifically those from the ICU, is now coming into in the front, and it's really an opportunity for us, all of us who are already in this area for a long period of time, to pick up this movement and try to bring the message not only for the COVID population but for the critically ill population in general, much further than we were trying to move them earlier on. So it's really an opportunity, and we learned actually that quite some of the things that we know already from pulmonary rehabilitation, from taking care of critically ill patients, are quite good, applicable also for this population. Of course, there are specific areas of the anxiety, the fatigue, which is much more prominent, and the care for family members, as was mentioned before. But this is really an opportunity for us to keep things going on.
Absolutely. Thank you. Amy?
Yes, so again, thanks for the invitation to be here today, and nice to serve on this panel. I think you're right. This is all about advocacy for physical therapy and physiotherapy and rehab for patients and them getting holistic care. And I want to come back to what Michelle mentioned. It's all about the team, and interprofessional education care is really the way that we can give our patients this patient-centered care and value-based care that they deserve. In the US, post-acute care is quite fragmented. And so anytime that we have a chance to come together and guidelines come out from physiotherapists, physical therapists, it's a step in the direction for us here in the US in order to get more access to rehabilitation for patients that need it. Currently, there are no ICU care pathways. Certain hospitals have set up those kinds of clinics, but it's not a standard here in the US. And I think this COVID and us coming together on an international scale is certainly helping the cause here for us to be able to move that pathway, potential for the pathway forward. And I think that's really what we need to concentrate on for our advocacy efforts.
Thank you, Amy, and thanks for joining us. David?
Yeah, I think I'm just going to go with two positives. I think it's nice to have positives in these sorts of times. I think one, to echo what Rick and Amy and others have said, that this is really putting the spotlight on something that's been an issue for a huge number of ICU survivors for many, many years. And I'm hoping this will create some momentum that we can change services at a structural level to really help support these patients into the future. And secondly, just to say, it's also really put a spotlight on the amazing job that physiotherapists are doing in intensive care, both from a respiratory and a rehabilitation point of view. I think we're at the forefront of fighting this pandemic, and I think it's a proud time to be a physio, and I think we're really making a difference for this group.
Thank you, David. And Sue, last but not least.
Well, firstly, I'd like to thank you, Rachel, for pulling this together. I think, it makes one of the strengths, I think, of physios is that we're a real community, and we all kind of get each other. It doesn't matter what country you're from. Those that are lucky to go to international conferences or have international visitors, we get each other, and we work hard, but we have fun together. And so thank you for your leadership in this area. I think the thing that we always need to remember is to do the basics well, and apply the knowledge that we know from other patient groups, that yes, COVID is different, but it's not, there are a lot of things that are very similar. So learn, go back to what we know. I think that we need to make sure that we support our staff that are working at the front line and those beyond, and find ways of giving them a break and recognising the stress that they're under. And I think that we have a great opportunity to leverage off this COVID pandemic to get some follow-up services to really shine the light on ICU survivorship more broadly. And I think that it is a real opportunity. When we first came together in 2010 to talk about post-intensive care syndrome, everyone was bemoaning the fact that we didn't have a champion, that Lance Armstrong was the champion for cancer, and that didn't turn out so well for them. But that this is a real opportunity for us as well to try and establish survivorship programs for patients and families to get the best outcomes. So thank you again. It's been a real privilege to sit on the panel.
Thank you, everyone, and thanks everyone in the audience